University and has been linked to SUNY Downstate as its key academic partner since its inception. In 2004, the Arthur Ashe Institute, in collaboration with SUNY Downstate Health Sciences University and the Office of the Brooklyn Borough President, created the Brooklyn Health Disparity Center to address health inequities through community engagement and research, education, and training. Arthur envisioned an institute that would conduct health education and research within community settings while being cognizant of the healthcare of those people that came from different countries and the healthcare of immigrants. Arthur envisioned building strategic partnerships. He also envisioned educating the next generation of people of color in the health professions. And he knew the importance of impacting policy to create lasting and systemic changes. The Institute continues to forward Arthur's vision through its community engagement and health promotion programs that takes place in community-based settings such as barbershops, beauty salons, faith-based organizations, and through its community partnerships such as leading the Communities Together for Health Equity Consortium, a consortium of over 70 community-based organizations that are situated across New York City, and community-based organizations that are focused on addressing social determinants of health. We also do the wonderful work through our Health Science Academy program that serves students of color in grades 6 through 12 as we strive to create a pipeline to the health professions for these students. Over the past 2 years, the relevance of the Institute's work has become even clearer as the COVID pandemic has highlighted the grave disparities within our communities and the need for outreach and health promotion within community settings such as barbershops or salons or places of worship, as well as the importance of diversifying the workforce has become even clearer to us. The pandemic has underscored that we, like our visionary leader and our visionary founder, are citizens of the world, as we have become more able to realize just how much we are connected as a people and connected throughout the pandemic. We are aware, though, that diseases do not appear in vacuums, and we need to address those other issues, what are called social determinants of health, such as housing and economics and racism, access to food, immigration, just to name some of those. And this is important to informing policy, which can have long-lasting systemic effects. COVID has also taken a toll on our mental health and well-being, and the psychological impacts we know are far-reaching. And so the Institute is working with others to bring mental health to the forefront and to address that. And as we look back on this year, we are thankful for all of you that have supported us. The list is too long and time does not permit to call out the names of all of our funders, all the names of our partners, our community partners, our community-based organizations that have stood by us throughout this time. Today, we would like to thank you for joining us. We would like to thank you for taking the time to be with us. And before I introduce our great speaker, I want to make sure that you're aware of some things, that there's a Q&A option. There's also a chat option. And I ask, as our speaker comes to you, that you populate the chat and populate the Q&A section with your questions. Again, I thank you for joining us. At this time, it gives me great pleasure to introduce our speaker. Linda Goler Blount joined the Black Women's Health Initiative as the President and Chief Executive Officer in February of 2014. And she has been very strategic and great in terms of moving the organization forward in its mission to achieve health equity, as well as reproductive justice for Black women. She has also done a lot of work in making sure that health and maternal health outcomes are brought to the forefront. Ms. Blount has worked at the United Way of Greater Atlanta, where she has led the effort to eliminate health inequities, also led the effort to address income, education, housing, things that now are called social determinants of health, and things that she has done all her life in terms of addressing to make sure that things are better and outcomes are better for people of color, and especially for women of color. She has also worked at the American Cancer Society, where she's provided strategic vision and leadership. She is an epidemiologist by training, and she has worked at the US CDC, the Centers for Disease Control and Prevention, as an expert scientist. She also has done extensive work internationally, working in Africa and Europe and the Caribbean. And Miss Blount's CV goes on and on with all her expertise and everything that she has done. And so today I'm so happy to welcome her as our guest speaker, as our lecturer for our 29th anniversary. And without further ado, I present our speaker for today. Thank you.
Well, thank you so much, Dr. Fraser, Marilyn, for that. I'm going to share my screen, and hopefully all of that will work well and we won't have technical difficulties. So can you see my screen, I hope?
Yes.
Okay, good. So thank you. This is really an honor and a joy to be able to, speak to you all today and hopefully have a conversation and afterwards. I think the legacy set by Arthur Ashe is part of what guides us and guides those of us in this work to try to realize a vision of what health equity might look like. And as Marilyn said, we've been at the Black Women's Health Imperative trying to make this vision a reality for Black women. And, we still have a long way to go, but we're trying. The Black Women's Health Imperative, just a little bit about us, was founded more than 38 years ago by Billie Avery. Billie brought 2,000 of her closest friends to Spelman's campus to talk about how Black women not only should take care of each other, but take care of themselves. So we were very much rooted in the self-care model. We had sister circles, self-help groups, and that went on for years. But as that work progressed, we realized that there were barriers, structural barriers, that prevented Black women from even practicing self-care. And so we built on Billie's history and grounding as an activist and a reproductive justice organizer to develop a policy focus so that we could change those structural barriers, and then to develop and deliver programs to Black women in cities, in urban areas, in institutions across the country, so that they themselves could understand what health equity meant for them, sort of at the personal level. So we are, the leading Black women's health organization. In just the almost 8 years I've been in this role, we've invested over $25 million in community-based organizations, in research and in policy efforts. And our focus is, I'm sure not surprisingly, in chronic disease prevention and risk reduction. We have a lifestyle change program funded by the Centers for Disease Control, and it is CDC's leading diabetes and chronic disease prevention program. And now we are an official training designation for all of their diabetes prevention. But we also focus on HIV prevention, maternal mortality prevention, as Marilyn said, reproductive justice, policy, and research. And a little bit about me. I've sort of came to this work, I like to say I have a bit of a checkered past, because I started out as an engineering major in data, and then worked at CDC, took a slight turn and not only left the country and got a sort of a different exposure to what health meant for Black people and health equity, but also went to work for a for-profit, Coca-Cola. And while that's not exactly consistent, I suppose, with public health, what I learned was the power of storytelling. And probably as many of you have seen with just the coverage of COVID-19, public health people don't really do a very good job of telling the story of health and engaging people in health. We tend to have to say everything, and we sort of joke in my field that nobody can put you to sleep faster than an epidemiologist. But what I learned was the importance of storytelling and bringing people into the story. Yes, we need data to talk about health, and I say we need data to tell the story, but we should never tell the story of data. And so what I bring to the Black Women's Health Imperative is an emphasis on research and science. And this sort of stems from just my general attitude, as my mother said from the time I was little. Um, I just always had that kind of an attitude. And when I was in elementary school, I integrated the school, wanted to play clarinet. We had the tryouts. And I saw on the sheet that the band director listed that I was assigned to trombone, not the clarinet. And of course, I was horrified. But even more horrifying was the notation next to trombone, which was thick lips. I never thought of myself as having thick lips. People in my community look like me, but I was surrounded by my classmates who are white who thought that was hilarious. So that was sort of my first experience with racism and discrimination. And I always sort of go back to that because so many women still experience this day to day and it goes unnoticed. And just a little bit about tennis. I actually played tennis in high school and college. But the fact that I'm here talking to you about this, I think gives you an indication of what my tennis career was like. So what do we know about Black women? When I first started, almost 8 years ago, we conducted a survey because we wanted to know how Black women defined health. So we did a qualitative survey. We asked Black women for words and phrases for what health meant to them. And about 80 to 85% of the words and phrases Black women use to define health were psychosocial. I'm calm, I'm at peace, I'm in control. About 10% of the words and phrases Black women use to define health were financial. I can keep a roof over my head, I can take care of my kids. Only about 5% of the words and phrases that Black women use to define health had anything to do with physical health or disease state. So what we took from that was Black women were saying, if I can get my mind right and my spirit right and my money right, I can take care of everything else. And it's not that breast cancer and diabetes weren't important. It's just that in our lived experiences, there were other things that were more important that we felt needed to be in place before we could deal with those things, or in order to deal with diabetes or breast cancer. And what bubbled up for us was that for Black women, stress was the #1 health issue for them. And as it turns out, Black women have about 15% more of a stress hormone called cortisol in their bloodstreams at any point in time than white women. And the thing that we know about cortisol is it is that fight or flight hormone. If your child is in a burning building, you can move mountains to get to that child, to rescue that child. But when cortisol is chronically elevated, it hurts us. It changes our metabolic response. So for example, if you give Black women and white women the same high-fat diet, Black women are going to gain more weight and gain it faster. If you give us the same low-fat diet, we're going to lose less weight and lose it more slowly. We know now that much of obesity among Black women is due to stress. Our doctors like to accuse us of not having self-control. But I would say if any group in this country has self-control, it's Black women. What we do have is considerable stress. So I just, because I'm an epidemiologist, want to talk a little bit about data. So we made great progress in breast cancer mortality. We see that the mortality rates have dropped steadily in the last 30 years. But the gap between Black women and white women hasn't closed. Today, Black women still die at 42% higher rates than white women, even though our screening rates are about the same. Black and white women get screening mammographies at about the same rate. If we go way back to the early 80s, in 1982, Black women and white women had the same incidence and mortality rates from breast cancer. And then in 1983, that changed. Well, what happened? We learned how to detect breast cancer and we learned how to treat it. So this gap that we see between Black women and white women simply reflects who got access and who didn't. And today it still reflects who has access and who doesn't. And we see similar trends in other chronic diseases. When we look at hypertension, Black people have higher rates of hypertension, Black women have higher rates of hypertension and cardiovascular disease and heart disease. We even know that when we present at hospital with heart disease, Black women are less likely to be believed that they're having a heart attack because our symptoms don't appear in the same way. And so we're less likely to get immediate treatment. The same is true for diabetes. African Americans, Black people have higher rates of diabetes, as does the American Indian population and the Hispanic population. And obesity, we know the data that we see all the time that 80% of Black women are overweight or obese. I'm going to come back to this story. I want to provide a little more context because it isn't quite as simple, I think, as healthcare providers and even some policymakers make it out to be. And in HIV, we see some really stark differences. In Washington, D.C., Black women have 19 times the rate of HIV as white women. In Atlanta, where I live, it's 12 times. This has nothing to do with their behavior. This has everything to do with how society is organized. And I'm sure you all have seen the many stories in the media recently about Black maternal mortality and the deaths that have occurred and near misses that have occurred among Black women who just weren't listened to by the providers. They complained of not feeling well, having problems, and weren't believed. So we saw what happened with Kira Johnson and Shalon Irving, who died. The near miss with Serena Williams. The thing about Black maternal mortality, though, it's a little bit different as when we think about other diseases, in that we sort of associate poverty and low income with some of these other disparities. But Black, educated, high income earning women have worse maternal mortality rates than white women without an 8th grade education. So this is not what we see in Black maternal mortality, and frankly other diseases, is not only an issue of poverty and not necessarily an issue of poverty. So why do these things occur? Back in 1985, the then Secretary of HHS, Margaret Heckler, issued the first report on African American health and health disparities. That report just talked about differences. It didn't get into an explanation of why they existed. The thing we know is that there's no biologic or genetic determinant for race. So that doesn't explain what we see. Since these disparities aren't due to genetics, we talk a lot about the social determinants of health that Marilyn mentioned. But what is interesting is, until recently, no one in public health ever stopped to ask why the social determinants of health exist in the first place. I mentioned stress. There's been a lot of research that is only now just coming to light about stress and what it means for our health, even though this research has been around for a long time. Tanae Lewis, a researcher at Emory, found that Black women have shorter telomeres, these cells at the end of our DNA that are frayed. The cell life is shorter. And what that means is it triggers our inflammatory response and our metabolic response, which could raise our risks for diabetes and heart disease. Arlene Geronimus coined the term in 1992 called weathering, where she talked about this allostatic load, meaning that Black women literally were aging faster than white women. So if you take two women, one Black, one white, 68 years old, for example, on average, the Black woman biologically is about 7.5 years older than the white woman. So we talk about, Black don't crack. On the outside, no, but on the inside, it's a very different story. And 3 years ago, the Kaiser Family Foundation conducted a study and found that 63% of Black adults and 45% of Latinos said that they've experienced racism directly in the past 12 months. And that they reported some 50 million days of poor mental health due to videos of police killing unarmed Black people. Well, we know that PTSD rates are up among Black women directly as a result of seeing these videos of police killing unarmed Black people and killing or hurting children. So now we can look at this data, look at the research, and finally bring it to light. This research, as I said, that's been around for a long time. Racial discrimination is actually causally associated with a number of adverse health outcomes. Fleda Mass Jackson found the relationship with maternal mortality. The Black Women's Health Study found a causal relationship between experiences of racism, uterine fibroid tumors in Black women, which then led to low birth weight babies and higher rates of infant mortality. And of course, we've seen it with obesity-related syndromes because of the impact on our metabolism and our inflammatory responses. A few years ago, I met with a researcher and we were having a conversation and I said, well, is it all bad? I mean, in public health, we always talk about what's wrong with Black women when we're talking about health disparities. And, this researcher said, well, in fact, the majority of the women in the Black Women's Health Study, some 60,000 of them, actually report their health as being very good or excellent. And I said, well, then why don't we tell that story? So a few years ago, we published Index Us, the first report, the first research on Black women's health based on healthy Black women, because we wanted to know what they did. What did they eat? How did they live? What was their work life like? What parts of the country did they live in? How did they combat the effects of chronic racial and gender discrimination? And so we put together this book as a guide for Black women to learn what others are doing. And since we published this, our research has been validated not only by the Black Women's Health Study, but by social media listening and what Black women themselves report. So in the last 30 years, there's been more than 700 studies that have determined a link or causality between racial and gender discrimination and adverse physical and mental health. More than 100,000 Black people die prematurely every year because of the effects of discrimination. A little more than 10 years ago, Adewale Troutman described it as a 747 filled with Black people dropping out of the sky every day. That's how many Black people die prematurely. And we know that of avoidable mortality among Black women, 60 to 70% of it is due to racial and gender discrimination. And so despite all of this work, some $200 billion has been invested in disparities research, disparities programs, awareness campaigns. Disparities are wider today in many respects than they were 35 years ago. And so if there are any business people in the audience, I would say that that's not a good ROI, and we're certainly not getting value for money. So we use at the Black Women's Health Imperative this research and what we learn from Black women to really inform our work, to take an asset-based approach rather than a deficit-based approach. And so coming on the heels of COVID-19 and looking forward, we're looking at what this means for data and research, for behavior change, and what this means for this emphasis on anti-racism. So, trying to follow in the footsteps and the examples set by Arthur Ashe. And as Marilyn said, we talk about the social determinants of health. Well, I think it's clear that racism is the social determinant of health. So when I think about data and analytics, what becomes evidence really depends on who's asking the questions and who they're asking, and frankly, who's interpreting the data, and certainly who's funding the research. The pipeline for Black and Brown researchers and clinicians hasn't changed in 40 years. It's still about 5% for physicians. And when we look at researchers who are funded at the highest level at NIH, these R01 researchers, less than 2% are of color. And that's been the same for 40 years. When we talk about evidence, it comes from clinical research. And people talk about Black and Brown people not participating in clinical research. Well, the number one reason we don't participate is because nobody asks us. It's not Yes, medical mistrust is part of this, but doctors make decisions about what we will and will not do and simply don't ask. And we've seen the dangers of what happens when we're not included in clinical research. Last year, with COVID-19, we found that pulse oximeters didn't work as well on people with dark skin. Dexamethasone, an effective treatment for those with severe COVID-19 disease, wasn't as effective on African Americans. Well, we were not a part of the research group that created the technology or the drug or the participants on which they were tested. The thing we know is that we can't pipeline our way to health equity. Even if we had unlimited resources, there aren't enough medical schools, faculty, fellowship programs, and training programs to actually significantly increase the number of Black and Brown researchers. We can't add another 100,000. So we have to look at something different. And in thinking about data and analytics, I also want to highlight that it is everywhere. It is sort of in some unusual places, like artificial intelligence. I published a paper with some colleagues earlier this year that looked at the bias that's in artificial intelligence that powers algorithms. We looked at the algorithms in electronic health record scheduling systems and found that they double and triple book Black patients. So this has some significant implications for health outcomes. If you don't have the kind of life that allows you to wait around and you can't keep coming and going to the doctor's office because you're not being seen, you're likely to not be seen, which means you're likely to suffer more severe disease and symptoms simply because of algorithms in scheduling systems. The Black Women's Health Imperative partnered with Stand Up to Cancer and Friends of Cancer Research to create a training program called TEACH to educate Black women on clinical research, how to participate in it, what to expect, and how to make sure that they're getting the right kind of treatment if they choose to participate in clinical science and research. And the We Must Count Coalition is a broad coalition of organizations calling for transparency and data reporting. We saw early in COVID-19, data weren't being collected by race and ethnicity, and they certainly weren't being reported by race and ethnicity. And when that happens, then we miss opportunities to actually improve health. And we also tell a very flawed story about what's happening in the health of broad numbers of people in this country. And what the Black Women's Health Imperative did to try to address this issue is, try to find partners who are willing to have these difficult conversations. My first few years at the Black Women's Health Imperative, I would get 5 to 7 calls every year from researchers wanting participants for their clinical trials, large pharmaceutical companies. And my answer was always no. I would tell people, I don't run a talent agency for your clinical trial, but I am really willing and happy to talk about why you're calling me in the first place. And of course, folks always turn me down. And I remember one particular instance where I was on the phone in a hotel lobby about to go into a panel presentation, talking with a major pharmaceutical company who wanted participants for their cervical cancer drug trial. And I said, no, but we should really have a conversation about why you're having such a hard time recruiting patients. And she said no. And I said, well, it just so happens, something special is happening today. Do you know what today is? And I said, this is the day that the movie on Henrietta Lacks is being released. In fact, I'm about to go in and have a panel discussion, on this film and the life of Henrietta Lacks. And this woman who had been talking to me about wanting participants for her cervical cancer clinical trial said, who's that? So this gave me a sense of, we've got a long way to go, and yet she wasn't willing to sort of have that conversation. Because as another colleague said to me, we don't want to talk about Tuskegee or J. Marion Sims. So we stood up this coalition, a $20 million coalition. It's got 179 members to focus on what needs to happen in clinical research, what needs to happen in the pipeline, how we can change provider behavior. Can we get providers to treat us all like we're their most favorite relative? What needs to happen in reimbursement policy, clinical trials participation, and research? How do we change the really burdensome informed consent process so that we can actually encourage participation? Patient and caregiver support and awareness. But importantly, where we're starting is with language. We talk about minority health. Well, who's a minority? In 20 years, the average adult will no longer be white. So who will be the minority in certain states now? Who's a minority? And so we have minoritized populations, and we're encouraging researchers, public health people to change their language. And this is true for diverse. Diversity applies to a group. I've had people refer to me as diverse. And of course, the question is, why am I diverse? So we've got a long way to go just in how we use language. But the important thing is really behavior change. We'd all like to think that positive change comes about because it's the right thing to do, but sometimes we have to legislate behavior. So for example, in policy, the US Preventive Services Task Force made a recommendation to raise the age of screening mammography. They've done this twice now, from 40 to 50. And they say, well, it's based in science, it's evidence-based. And that is true. Their recommendations absolutely are based in evidence. They're based on studies performed in Sweden and Canada, where there were no Black women. And so I've said to them, if Black women get breast cancer on average 5 to 7 years younger than white women, if 25% of our breast cancers occur under the age of 50 and 8% occur under the age of 40, why would we wait to start looking for breast cancer? If we do that, another 12 to 1,300 Black women would die every year from breast cancer. We need to change this kind of behavior. We need to look at insurer behavior. I'm pretty sure that if we had quality measures that incorporated race, ethnicity, and gender, we would see Black maternal mortality rates drop dramatically if providers didn't think they'd be reimbursed because they weren't meeting these quality measures. And we have to look at what happens in social policy. David Williams talks about systemic disinvestment in Black communities. And he says if we could eliminate neighborhood racial segregation, we actually would eliminate health disparities. And back to physicians, still 30% of physicians believe that Black people don't feel pain as much as white people, that somehow we have thicker skin. And there was a study published just 3 years ago that looked at fourth-year medical school students who were not as likely to prescribe HIV prevention medications to Black women because they said it would only encourage them to go out and engage in risky sexual behavior. And we also have to look at funder behavior and from foundations and governments. We got the opportunity to work with some NFL athletes last year to talk about sickle cell. There are 100,000 people living with sickle cell disease in the US now, about 30,000 living with cystic fibrosis. Cystic fibrosis funding is 7 times that of sickle cell funding. And what was interesting is these athletes talk about not being tested for the trait, even though testing is supposed to be mandatory for babies. And many of them talked about not finding out that they even had sickle cell disease until they were adults. So, I think the experiences of the last 2 years almost have really crystallized the role of racism in health and in society. Last year, at sort of the height of COVID-19 and right after George Floyd's murder and Breonna Taylor's murder, I had many colleagues say, I had no idea. I had no idea health disparities was still a thing. I had no idea that racism and police violence was such a thing. I had no idea they were related. And most perhaps, Fortune 500 executives put statements of outrage on their websites, expressing their dismay at police brutality, at racism, at health disparities. But very few of these executives said, and here's what we're going to do. Some $49 billion has been pledged to fight these issues, and so far less than $2 billion has actually been allocated. So the CDC director declared racism as a public health crisis. So that then gave the Black Women's Health Imperative sort of that opening to finally deal with this, we hope, in a way that people can really understand it and act, change their behavior. That's why we created the first ever anti-racism workplace initiative. It took 10 years for Black women to recover from the housing crisis and the recession of 2007. Last year, 2 years ago, let's say, Black women were not considered essential, but suddenly we were essential. And so Black women and Latinas were the ones who often couldn't work from home and had to go out in public, ride public transportation, face an often unmasked and angry public. And we were the hardest hit by the pandemic of business closures and lack of access to care. So this anti-racism initiative focuses on women in the workplace to address the issues that we've been talking about: pay equity, less support from managers, less mentorship, the fact that we're hired and promoted more slowly, lack of prioritization of our skill set. And what was interesting was just recently we saw in the Washington Post that those Black women who could work from home were now dreading going back into the office for fear of having to deal with these what are called microaggressions that never feel micro. Having to go back into the office and being questioned about why our hair is different today, or why are we so dressed up for work, or gee, I don't know how you walk in those heels. It's those things that we're constantly subjected to that wear on us and actually influence our health. And because the majority of Black women work, we decided to focus on the workplace. So last year, we saw another really important development with COVID-19 and diversity, equity, inclusion. Suddenly, Black employees became de facto DEI experts. And many of them are being called in to explain police violence, explain health disparities to their coworkers, when they really were not qualified to do that. And it highlighted for us the problem, the fundamental problem with DEI, and that's in its very definition and implementation. Inequity is built into it because DEI assumes, for one thing, that Black people or the object of DEI somehow needs to be fixed, that something's wrong with them. And there's also an implied power imbalance. If DEI has become that thing that one group does to or for another group, so everybody's aggrieved. The group that's in power feels like, oh, now we've got to do something for these folks. And those people who are the so-called recipients of DEI are made to feel as though they have no power and they need to be fixed. So our approach with our workplace initiative to deal with anti-racism is fairness. People don't know what equity is. When you ask for definitions of equity, you get too many to count. But people know what fairness feels like. And fairness is a zero-sum game. It's either fair for all or fair for none. And so our focus with our workplace initiative has been to look at those metrics that need to be measured, the evaluation strategies, the implementation strategies that we will work with corporations on, and also invite them to be very transparent about their journey so that they can make the progress that they talked about to get to a fair workplace, to be committed to the health of their employees, so that they can do the things they say they want by attracting and hiring and promoting and retaining top talent. We also have, as a part of this initiative, our Artful Wellness Toolkit, anti-racism toolkit for Black women, so they can look at these same metrics and make the best decision for themselves about whether or not that workplace is the best for them. So we hope that corporations will be transparent, will invite us along on their journey. But we also, through this initiative, will be able to see what is happening and be able to evaluate progress and call it out when it doesn't happen. So we're inviting our corporate partners to follow Arthur Ashe, and to be fearless. I mean, we say to Black women, you know, be careful when you're going in for health care. Make sure you get the health care that you deserve. No is a complete sentence. And if you're not getting the health care you deserve, you know, treat your provider like the cable repair person. You wouldn't take bad service from that person. Don't take it from your healthcare provider. Breathe, practice self-care, be true to our roots in self-care. Vote. One of the most important things we can do is vote, just in the off chance that people don't do something because it's the right thing to do. We have to legislate behavior. And then be like Arthur Ashe, be fearless in the support of fairness. Thank you.
Thank you so much for that wonderful presentation. You know, as you were talking about the various things, certain things just stood out when we talk about social determinants of health, and we talk about racism as being one, but a lot of the things that you pointed out lead back to having a racist system and a system that needs to be changed. One of the things that I wanted to ask you about is, how do we make people accountable in the systems that we're in, whether it's an academic system where you may have things that are not equal, whether it's a corporate system or even government systems. How do we make people accountable in terms of addressing those issues?
You know, Marilyn, one of the things we've got to do is paint a very clear picture of what fairness looks like. You know, what are those behaviors? What are those measures? And communicate them, but call out when they're not being met. Academic institution leaders, corporate leaders, everybody last year and this year still says we're all about equity, we're all about fairness, some say. We think what happened last year was, an abomination. But as I said, they didn't say what they were going to do. So we can then say, well, here are the things to do. If you really mean that, here's how you create that vision that you're talking about. The challenge, of course, is with the DEI world, but just in society in general, it's easy to say we want this change. We're horrified by what happened. But as many healthcare executives have said to me, oh, that DEI thing, that's great, but we don't need it. We're fine. So the problem is people don't see themselves in it. Like, I don't want to change anything about me or what I do or how I run my operation. Yes, I'm all in favor of diversity, equity, and inclusion, but I don't want to have to do anything different. So part of this is legislating that behavior. There has to be repercussions when people don't do what should be done, and transparency. People need to call it out. Since it's on their websites, that's going to live forever. So we always have this point to come back to say, well, did you mean it then or do you mean it now? And what have you done? And we're trying to take the carrot approach by saying, with this workplace initiative, we're giving you some tools and strategies and metrics, but we're also watching to see what actually happens.
Thank you so much. And oftentimes people may not feel as though they have the voice, right, to actually do that and to make the change. So I was really happy when you said that sometimes we need to treat our healthcare providers the way that we would treat the cable person, right? Because we wouldn't take certain service from some people, but sometimes we feel as though we cannot, we don't have that voice. So the transparency piece is so important. And I applaud the work that you all are doing in terms of like making people be aware of the things that are out there and doing it. And I know that you talk about equity, and I just want to ask you personally, what does it mean to you when you talk about equity? What does equity mean for you?
My definition of health equity is if there were no barriers to anyone being able to make the choices to do the things they need to do to be as healthy as possible, whatever that state of health would look like would be health equity, because there's no barriers. It's not that we all have the same health. That wouldn't happen. It's not that the same thing happens for all of us. Obviously, that that doesn't make sense. We've got to do different things. But whatever that state of a population's health would be, if there weren't these artificial barriers, is we could declare success. We could call that health equity. But the problem is we don't have that. There are barriers. We saw with COVID-19 when testing first came on the scene. I'm looking at, thinking about Atlanta, testing sites were either at academic medical centers or in the suburbs. Well, if you didn't have a car, were you going to take public transportation or pay for Lyft to drive a half an hour, 40 minutes to get a test? Probably not. Same is true for treatment and getting a vaccine even. And we don't automatically organize our systems of care delivery to meet the needs of the population. We organize them to meet the needs of a certain population.
Yeah, and when you talk about even being intentional with our language, right? It's like how do we do that? What's the best way of us doing that? Because we still use words that are so loaded, even when we think about when you have a proposal that's being sent out, or even the proposals that come down and it's like, okay, a minority population, and the word, what it means. And I just want to hear some of your thoughts, and how do we become intentional with the language that we use, even from smaller organizations, and even for ourselves when we're putting things out there.
I think we all have to be, we should be very careful. I mean, it's tough, as you know, if you are a sort of mid-level Black or brown employee, to really talk about this, because there's a risk, obviously, potentially to your career or your job. But those of us in leadership need to sort of be out front early and often about language and how harmful certain language is. I think a lot of people don't realize how harmful it is. I mean, we're just sort of used to talking a certain way. And so people don't realize that calling somebody a minority, I mean, that's a math term, but we've turned it into a pejorative, or referring to people as diverse. They're not understanding that when I call somebody diverse, then I'm implying that there's a standard to which I'm comparing this person, and they're not that. They're
Yeah,
diverse.
yeah.
So I think it's going to take media, it's going to take leaders. Awareness is really important. It's necessary, but not sufficient. But we get the opportunity to work with some fairly high profile folks who can then say that, who can deliver that message. And I think it's going to take recognizable, trusted people to keep saying that. People don't generally want to hear from an epidemiologist, but they might want to hear from Mary J. Blige, or from some of these NFL players, or other well-known people. And also well-known white people, Anthony Fauci, or the CDC director, also have to adopt this language and be careful about what language they use when describing data and race and gender specifically.
Yeah, and awareness, as I said, it is important, but how do you even go further than the awareness? Because people were so to speak, aware of health disparities suddenly, right? That when you saw things that happened with COVID, that's okay. Yeah, we have inequities here in healthcare. When we saw the murder of George Floyd, that people were like, oh, there is racism, and things that we have known all the time, and things that have happened all the time. And now what do we do with that awareness, right? Like how, and that goes back to the accountability question, in terms of making people be accountable for what they said. There are a lot of statements, as you said, that were put out there. And those statements, how do we make sure that people are linking those statements to actual action, right? One of the things that I like, that I really appreciated your saying, is when we think about clinical trials and people being involved in clinical trials, or even being involved in research. Years ago, we did a program on HIV and AIDS in barbershops, and we were asking the barbers and the men in the community about participating. And they were so appreciative to be asked to participate in research. And they said what you said, that no one has ever asked, right? And folks would say, well, people do not want to participate. People of color do not want to participate in that. And and as you think about clinical trials, how do we how do we make sure that we are at the table as people of color? How do we make sure that we are at the table in the way that we want to be at the table, and it's not seen as there's a pool to pull from? As you said, you're not a talent agency for people of color to participate in research.
Yeah. I hope that what we have seen this past 2 years with COVID might resonate and spur some different behavior among researchers and funders. I mean, it can be deadly when you leave people out of research. And what you hear oftentimes is, well, we don't know how to do the recruitment. We don't know how to do the outreach. Well, there are people who do. Part of research is sometimes it becomes an issue of convenience. We know this group, this is easy, we can get these participants because we need to move on with our research. But we need researchers to think beyond just their study and understand that our demographics are changing, and the people who participate in research and the drugs that are developed, more importantly, from the research or the technologies will have a broad application, but if they're not inclusive, then they may not work, which could be harmful. One of the things that we say to researchers when if I'm at a scientific meeting is for white researchers or researchers who are not Black, part of this is your own social and professional network. So submit papers, abstracts at the National Medical Association, the National Black Nurses Association meeting, the American Black Chemical Engineering Society. These are all research scientific meetings. Submit abstracts, go and present. And I actually had a participant in the meeting. I didn't know this person, but he came up to me after this meeting and said, I did that. And wow, I found out that, there were people doing the same thing I was doing. And now I've got a whole other set of colleagues. Well, yeah, of course. We know historically why NMA had to be created and these other organizations, because Black people couldn't be a member of the AMA. So if we could get people out of their social and professional networks, that might help. But in the meantime, I go back to, we have to legislate behavior. The FDA has diversity requirements that they don't enforce. They need to start enforcing those diversity requirements to ensure that there is participation from a broad cross-section of the population in any study that's funded by the government.
Yeah. And then, Linda, I know that you have done extensive work abroad, and even thinking about some of those health systems. I know we are all connected in a sense as we think about it. What are some of the parallels that you've drawn from there, or some of the differences, or even lessons learned that we should probably even think about as people of color in this country?
Marilyn, it's really interesting. I did a fair amount of STD surveillance work in the Caribbean and in South Africa and Malawi and Zimbabwe. And it was interesting to see how the NGO community worked there as compared to the way nonprofits work in this country. I found it was much more collaborative. You had fewer people, obviously. And so when we were in, I lived in Trinidad, or if I was in Jamaica, or if I was in South Africa, the NGOs had to rely on the people there in the country who had expertise, who had the knowledge of the population, the environment, the economics, the systems, to help sort of co-create the work that they were funding. But we don't see that in this country as much. With the nonprofits here, we see researchers and other organizations sort of dropping in to do something in the Black community or the Latino community, collecting the data, disappearing, and people in that community never know what happened to the data, what happened to the research. They're not included in the design of it. They don't know. So what the message they get is, you're just there for us to study and further our research, but you don't really have any value beyond that. And so we see something very different. This is not to say that colonialism isn't still rampant in countries in Africa and the Caribbean, but there's more of a dependence and there's more of a collaboration. We talk about that in this country, but we don't see it as much. So we absolutely could take some lessons learned, and funders, researchers, to your point, if you go into a barbershop, researchers' job is to be quiet and listen. what do you wish you had? What don't you have? What, if you could redesign this system, what would it look like? That's how we should approach our research in this country and our community-based interventions. Because if not, then we keep getting what we have. And we've been doing health disparities work in earnest for, what, 35 years?
Yeah, and I just have a few more questions, just two more questions. Linda, one of them relates to pipelines, and you talked about that in terms of when you show the stats that we're where we were 40 years ago, right? And how do we change that? How do we move the needle on that to create equity, but also to improve and increase people of color in health professions?
Well, this is an issue where we really have to go way back. When we look at public education and the way it is funded, there are obviously gross disparities. By having concentrated and persistent poverty and having a public school that's funded based on property taxes means that schools that serve low-income students can never be successful, or almost never be successful, because there's just not the resources. And so, we end up with a situation where we take the best and brightest Black students or Latinos out of their communities and put them in another school system, which, frankly, has its own set of sort of emotional and mental health issues. If we changed our policies and just funded our schools, then all of that brilliance, all of that talent that exists in low-income neighborhoods would then have a better opportunity to then go to college and then become the scientists and researchers. As I said, we don't have enough capacity. Even if we could get another 100,000 Black and brown people into the sciences, we don't actually have the capacity. But we do have room for improvement. But until we address how we educate our young people, we're going to end up having this situation. And again, I'm always going to go back to legislating behavior. If we don't have specific requirements, universities have gone back and forth about requirements, their diversity requirements. If we don't legislate that kind of behavior, then there's always a reason to exclude people.
Yeah, exactly. And one of the last questions I wanted to ask you, how do we take care of ourselves, especially women of color? We do a lot of things, and how do we integrate wellness in that? And it was interesting when you talk about when someone may ask us about how we're doing our health, and it stems to the things that we have need for, and if we have a roof over our heads, or if we are feeling happy today, and those kinds of things. But how do we really take care of ourselves?
Yeah. I think one of the things that we can do is first recognize that solving racism is not our burden. It ends up being put on us. That is not our problem to solve.
Mhm.
And so we can let that go. Nor is solving health disparities our burden. But as Black women, what we talk about and what we want to see is more connection, because we saw what happened last year and this year when we can't connect. And there are forces at play that are trying to keep us from making that connection. If we can do that, I used to tell folks last year, check on your sister, call her up. I could call you up and say, hey, Marilyn, how you doing? And you say, oh, I'm fine. But I could look at you and say, no, you're not. Come on, just tell me. We're busy. I understand that, but we really need to mind our sister's business. We really need to let her know there's somebody there that she can count on, and that we need to know there's somebody there we can count on. I tell Black women all the time, make a list. We're all stressed. Make a list of your big stressors. Make a list of people who can help, even if you haven't talked to them in years. Draw a line between whatever that issue is and that person, and then call them. Just like we never say no to anybody, that person isn't going to say no to you. Build your network, be connected, be involved, and of course, vote. That is one of the most important things we can do for our physical and mental health.
Thank you so much, Linda. As someone said that they always learn a lot from you, and thank you for this powerful presentation. Thank you for being with us. Before we go, I want you to make sure that you put your website, in the chat so that if anyone would like to learn more about the wonderful work that you all are doing and in terms of your leadership at Black Women's Health Initiative, that they have access to that. You'd mentioned index us, and I want people to look into that as well. And I just want to take this time. This has been our 29th anniversary. We're celebrating it today. And next year, it's going to be 30 years of the Institute, and we look forward to your joining us then again. But I just want to take this opportunity to thank everyone for being here. And Linda, we just thank you wholeheartedly for taking the time out of your busy schedule to be with us and to inform us and to talk to us about these issues that are very pressing and very important to our community. So
Thank you
thank you
so
so
much,
much.
Marilyn. Thank you. Take
Thank you.
care.
Take care.